With a chest incision for a mitral valve, we typically make the incision about 3.5 to 4 centimeters. It needs to be a certain size to be able to get the left atrial retractor in, so generally that's about 3.5 to 4 centimeters. We'll make it underneath the crease of the breast on the right side, and it's pretty important to try to get into the fourth interspace. If you're a little too low, you're going to really struggle, and so we make an effort to get into the fourth interspace so that we can look directly across with a 5mm scope and see the pulmonary veins entering the left atrium.
If you're operating on a non-redo, I opened the pericardium way up over the aorta, even though I was going to operate down on the left atrium. And the reason for that is that I can look at the aorta, especially during the time of balloon inflation, and you can see where the balloon is inflated and where the root of the aortic root is collapsed down by the vent. And it tells you exactly where the balloon is. It's very reassuring. It tells you the balloon's not too low. And then you give cardioplasia, it fills back out, put the vent back on, sucks back down.
There's a little trick as far as prepping. And what I do is I use the I-band drape to pull the breast. After I mark the breast in its normal position to find the crease, then we pull the breast superior with the I-band drape and hold it up, and then you can get pretty high.
It makes it a lot easier if you have a double lumen tube in. I did a lady fairly recently where our cardiac anesthesiologist, who are extremely skilled at a double lumen tube, couldn't put one in. It wasn't a big deal at that point in my learning curve. We just went on bypass through the groin, and once we're on bypass we could deflate the lungs, and I just opened the pericardium after we were on pump. It probably added an extra 10 minutes total to the pump run. It wasn't a big deal. It's maybe not the way you want to start, and I think it's nice to have a double lumen tube, but it's not necessary.